So, immunotherapy. So this is the hot ticket item for probably prostate, bladder, and again, I'm going to kind of come at this a little bit of a different fashion. Not so much focusing on individual drugs, although we'll talk about a few. But again, we hear these terminologies. We hear about checkpoint inhibitors. We hear about CTLA-4. We hear about PD-1, PD-L1. We hear about co-stimulatory molecules. And so, again, I think if you want to understand how these drugs work, you really need to go back to Immunology 101. It was interesting when we were first talking about this a couple of years ago. Lenny Gamella said, when I was a medical student, immunology was like a 2-week course. And I'm not sure what they're teaching now, but I'm sure it's more like a 2-year course. So these are my disclosures. So let's talk about immunotherapy. So I love this slide. So these are all the sort of the current therapeutics that can be used for the management of metastatic castration-resistant prostate cancer. Again, the traditional ones, the cytotoxic chemotherapy, including docetaxel and cabazitaxel. Again, Dan has started to outline, again, these targeted therapies looking at particular drivers. We've talked about hormonal therapy. We also know that there is a lot of attention being paid to bone-targeting therapy, including anti-resorptive agents like denosumab or zoledronic acid, but we also have a alpha emitter radiopharmaceutical agent that's FDA approved with a survival benefit that's radium-223 or Xofigo. But what about the immunotherapy? And so, this is where we're going to concentrate a lot of our efforts. Again, it's going to be more theoretical. It's going to be hopefully a little bit educational. So I think I stole this slide from Neil, and this was the sort of the front page or the cover. And again, we've been looking at cancer immunotherapy for a number of years, and it's becoming more and more across all tumor types. And as many of us, this is where, in terms of bladder, which has sort of been not much going on, immunotherapy is making a big mark. This is courtesy of our friends at Dendreon. So, this is sort of the transition as we've gone in terms of the historical nature of and the renaissance of immunotherapy. We started off really back in the early days where Dr. Coley was really looking at he noticed an association in patients who he was treating for sarcomas that actually got infected. And the original Coley's toxin actually was what Dr. Coley did, is that he actually took extracts of basically strep and serratia and would actually inject them into the tumors. And he was a general surgeon in New York, I believe, and was actually injecting this formula into tumors, and actually saw he had some element of a response. So just a little bit of trivia, this really got his attention because he had a patient that died after an infection, and I believe the woman was somehow related to John D. Rockefeller, and that's where Rockefeller started getting into and donating more to medical research. But again, we've been using as urologists, we've been using BCG for management of non-muscle invasive bladder cancer for many years. And again, you've had this whole proliferation of agents with various types, and really, again, it's all immunotherapy. So it's a rather encompassing term. So this is sort of what the microtumor environment kind of looks like. We've got basically your cancer cells, you've got macrophages, you've got natural killer cells, you've got T cells basically, which are responsible for cell-mediated response. You've got these dendritic cells, which are part of the APCs, myeloid-derived suppressor cells, and also B lymphocytes, which are responsible for antibody production. So again, these are kind of all the cells that are really make up part of your immune response. So again, T cells, B cells, these are all antigen specific. These natural killer cells, these NK cells, these are cytotoxic lymphocytes that recognize and kill stress or malignant cells independent of antigen activity. So then you get these antigen-presenting cells, which are really important for T-cell mediated response. And again, this is sort of what it looks like. So again, on the left, you've got this is being driven by the B lymphocytes, which results in antibody production. And then over here on the right, this is all basically driven by the T cell. So, how does this all start? So, really what happens is that you get antigens that are presented, but the antigens and this happens in the lymph node tissue, in the lymphoid tissue. The antigen by itself just doesn't cause a response. It has to get presented to the immune system, and so it gets taken up by these antigen-presenting cells, these dendritic cells. They then this then results, and we'll talk about this later, this results in activation and priming of the T cell. So then, again, the antigens get expressed, the T cells get activated, and then what happens, it goes into the peripheral tissue. These are now replication of antigen-specific T cells, and then you get this whole downstream effect, which is, again, is the cell-mediated response. So you get a B cell response and you get a T cell response, and it's very important to, again, to really understand that. So in terms of immunotherapy, what we know is that since 2010, and even before, there have been more than a dozen different immunotherapy agents have been approved, with the majority over the last decade. Immunotherapy agents currently approved, there's greater than 10 in various cell types. And again, this is an old slide, and all this is expanding rapidly. But in terms of a therapeutic vaccine, so the first therapeutic vaccine, the only therapeutic vaccine that's approved, is actually in metastatic castration-resistant prostate cancer, and that's Sipuleucel-T. That was approved in April of 2010. Again, we showed this slide earlier. M0, there are no therapies. There are no therapies approved that have a significant survival benefit. And so again, that's why we have all these great M0 trials as we try to move, especially some of these early hormonal agents. I know a couple of companies are now looking at also trying to move in some of the therapeutic vaccines into this M0 space. But for right now, this is a real problem because, again, it's either clinical trial or observation. But like I mentioned before, I think with some of these newer imaging agents, which includes FACBC, PSMA, choline, we are probably going to see more evidence of metastatic disease, which again opens up our playbook, if you will, to all these newer drugs. But suffice it to say that in the M1 castration-resistant prostate cancer patient, the current management is, again, maintain castration levels of serum testosterone less than 50. Vis-a-vis, they need to stay on LHRH therapy. Consider bone anti-resorptive therapy with denosumab or zoledronic acid. If the patient is asymptomatic or minimally symptomatic, no liver mets, life expectancy greater than 6 months, ECOG performance status less than 1, you should really consider the use early on of Sipuleucel-T. Again, the only approved immunotherapy right now in metastatic castration-resistant prostate cancer. If they're symptomatic, then you should consider palliative radiation for painful bony mets, as well as best supportive care. And then from there, the breakout is whether or not they have visceral disease. And again, we have the whole menu of drugs that we've been talking about. So in terms of Sipuleucel-T, again, this was approved in April of 2010. It is an autologous immunotherapy, and many who in the room has ordered or personally delivered Sipuleucel-T in their practice. So again, we got about a handful of patients or a handful of people. So as many of you know, basically how the drug works is that you had this is based upon the on prostatic acid phosphatase. It's exposed to an antigen-presenting cell, and this happens. Basically, this all happens ex vivo. So we actually, how this is done is that we send the patients for an apheresis. We pull out about 5% of their antigen-presenting cells. We then actually incubate the patient's own antigen-presenting cells, their APCs, their dendritic cells, with this fused antigen of PAP and GM-CSF. The APCs then take up the antigen. The antigen is processed and presented on the surface of the antigen-presenting cell. These cells are now fully activated, and so now and so the drug itself, it's the patient's own white blood cells, dendritic cells that have been activated by the uptake of basically prostatic acid phosphatase. Then this process takes place. It's the most difficult part of actually delivering Sipuleucel-T. It's not the drug itself. It's not giving back the drug. The apheresis portion takes about 3 hours. It takes about 3 hours. But after that, it gets back to our clinic. 3 days later, we then, the patients sit in a recliner. They get an IV. This thing is then infused over 1 hour, and they go home. And so and then at that point, you get T-cell proliferation and attack of the cancer cells. It's completely driven by prostatic acid phosphatase that has been taken up by the patient's own antigen-presenting cells. So again, this is sort of it's sort of what we call this prime boost regimen, improves the size and the quality of the anti-cancer immune response. So this strategy is basically you get this priming dose, you get this expansion of a larger pool of activated T cells, and because of the memory effect, when you do it again, Sipuleucel-T is given every 2 weeks for 3 cycles. And again, because we have memory, is that it generates long-lived memory T cells for long-term for anti-cancer effect, and then you get this cascade effect of antigen spread, which we'll talk about. So many of you know. So this was their registry trial. It's called the IMPACT trial, which stands for Immunotherapy Prostate AdenoCarcinoma Treatment. 512 patients, all with metastatic castration-resistant prostate cancer, asymptomatic or minimally symptomatic, randomized 2-for-1 to either receive Sipuleucel-T every 2 weeks for 3 cycles versus placebo. They monitored progression, but the primary endpoint was overall survival. If the patients did progress, they could be treated at the physician's discretion. And again, you know this data, but this is the IMPACT overall survival data, is that in the Sipuleucel-T arm, the median survival was 25.8 months. In the placebo arm, this was 21.7 months. That's a 4.1 month survival difference, which was statistically significant. And again, Sipuleucel-T was approved by the FDA here in the United States, and it's only available in the United States in April of 2010. So it's interesting, Paul Schellhammer, a good friend of ours, prostate cancer survivor, they actually took this data. And so the median PSA in IMPACT was about 55, I believe. So what Paul did is that they basically broke out the patients in PSA quartiles. So the various quartiles were patients, and again, they tried to do this in a very even fashion, 128 patients per quartile. PSAs less than 22, 22 to 50, 50 to 134, and greater than 134. And basically what they did is they said, okay, what's the benefit if patients have lower volumes of disease vis-a-vis lower PSAs? And again, this is why I was trying to make that point earlier. This is the problem that urologists get into. We have created this whole generation of PSA addicts. We follow PSAs, but this is, as many of you know, the problem with this trial is that there was not a PSA effect. The PSAs did not go down after treatment, but the patients lived longer. But what Paul figured out, what they found here is that patients with lower PSAs, lower volume of disease, had a longer survival benefit. Now that survival benefit held for all 4, but clearly the best group were people with lower PSAs. And again, remember what PSA is. It's an androgen-driven event. It is a protein that's a function of transcription and translation that's driven by testosterone binding to the androgen receptor. So if we take out testosterone, it's really, put it simply, the cells are making less PSA. So think of it this way. If you have 2 patients and they have 3 things in common. They've had a radical prostatectomy, they have PSAs, they have prostate cancer, radical prostatectomy, and they both have PSAs of 3. Let's just say 3. What they don't have in common is the first patient's never been on hormones, he's hormone naive, and the second patient is on androgen deprivation therapy. If I just asked you a simple question, who has more disease? Is it the first guy who's hormone naive? Is it the second guy who's on hormones? They have the same amount of disease, or you don't know. You know, it's got to be, for the most part, it's got to be guy number two, door number two, because his testosterone levels are already low. He's making less PSA. And so this makes perfect sense. This forms the basis of why we have advocated for the urology world and everybody. If you've got a patient on androgen deprivation therapy and their PSAs are going up, albeit small values, you better start looking for disease. Because this highlights that if you start these patients early on therapy, they will live longer. Now, this study was not powered. Study was not powered, but again, this is pretty significant. And again, if you understand the nuances, especially in the control group of impact, it becomes even more meaningful. So again, I encourage you, again, be looking for these patients if they're on ADT when they have small bumps in their PSA. And again, people have asked the question, because remember, Sipuleucel-T, we're actually driving it off the epitope of prostatic acid phosphatase. We're only targeting one antigen. And again, we know prostate cancer cells basically express multiple different membrane antigens. But what happens is that once you get cell kill, then you get release of these antigens. Then what happens is that you get this antigen spread, and so even though you're only targeting one particular antigen, in this case PAP, you still get spread and uptake of these other antigens, which can result, again, in an enhanced immune response. And actually, they looked at this, looking at various expressions of increased antigen spread was associated with actually an increased overall survival, basically if it was PAP only, 2 secondary antigens, or 3 secondary antigens. So again, this concept of antigen spread, even though Sipuleucel-T is only targeting one antigen, once you get cell kill, then you get this antigen spread. Again, they've actually looked at Sipuleucel-T. This was a small trial. This was reported in 2012. They actually used Sipuleucel-T in a neoadjuvant setting before radical prostatectomy. So again, this was histologically confirmed adenocarcinoma of the prostate, non-metastatic. They underwent radical prostatectomy. They were scheduled to undergo radical prostatectomy. They received Sipuleucel-T as we would if you were a CRPC patient. They then underwent prostatectomy. They then got a booster 12 weeks post-radical prostatectomy and then followed up. What they found here was interesting, again, is that they saw a quantification of lymphocyte infiltration in the tissues due to the Sipuleucel-T effect. So it's an active drug. This has been questioned multiple times. A lot of our medical oncology colleagues don't really believe in Sipuleucel-T because they don't understand how it works. The fact that there's no drop in PSA really is befuddling. But again, we know, as can't remember who I guess it was James Eastham. This is the data. The patients, no doubt, they live longer. So I tell my patients, hey, you want to have a low PSA, or would you rather live longer? So again, Dendreon, as you know, they have just been purchased by a Chinese company. They're involved in multiple trials, again, looking at Sipuleucel-T. They've also looked at some very small studies. They've also looked at some very small studies combining it, as what Dan was talking about, with basically some enzalutamide as well as abiraterone. And again, those studies were actually driven to make sure that if you had concomitant use with some of these other agents, that it would not affect the upregulation of the immune system. And again, this is kind of what it looks like, basically looking at this roller coaster slide in the various phases of prostate cancer. There's another immunovaccine that's out there, and you probably know about this. This is basically Prostvac Tricom. It is basically using a viral vector. This is actually how it's a recombinant cancer vaccine. Again, looking at using vaccinia, fowlpox. This is PSA driven. This is given there's no apheresis required for this. This is a series of injections. Their original trial was a phase 2. This was reported out in 2010. Again, this was for asymptomatic or minimally symptomatic CRPC patients. They got randomized 2-for-1 versus an empty vector and placebo. Again, with the endpoint being survival. And as many of you know, this had a very significant survival benefit of about 8.5 months. And this was a phase 2 trial. As many of you also know, the company that originally did this trial ran out of money. Phase 3 wasn't really started for a few years later, and at that point, the problem is that you now had other drugs that were already FDA approved. So they did start a phase 3 trial, which was the Prostvac trial. Probably many of you put patients on this trial. And again, this was for a minimally symptomatic or asymptomatic CRPC patient. They basically got low-dose adjuvant Prostvac plus GM-CSF versus Prostvac versus placebo. This trial is fully accrued. And Neil, when are they going to be reporting that out? Sometime this year? Yeah. So again, another immunovaccine. It's a true vaccine. The difference with this generally is, like we talked about with Sipuleucel-T, that requires some element of apheresis. These are all subcutaneous injections. So again, when you look at sort of, again, what's central to immuno-oncology is basically the T cell, the activated T cell. So start thinking about some of these agents now. What I want you to do is think about active immunotherapy versus what we've been talking about, what Dan's an expert on, is this immune checkpoint modulation. So active immunotherapy, like Sipuleucel-T, it's targeted activation. And remember, for CIP-T, we're targeting PAP. It's antigen spread. It has variable efficacy, limited biomarkers. But the beauty, why patients really love CIP-T, it is very easily tolerated. It's very easily tolerated. I've been involved with over 600 doses. We do it in the office. It's about an hour infusion. I think we've had 2 patients that have had a rigor, no hospitalization. The biggest complaint that they have, usually after the second infusion, is they get some myalgias, almost like a flu-like symptom. But what about this thing that we keep hearing about, this checkpoint modulation? So if you think about kind of in general what the immune system does, what does it do? The immune system, it has to recognize self, right? It has to recognize you. And therefore, it can't just go crazy because it has to recognize you. So that's why some of these autoimmune diseases, like rheumatoid arthritis, there's a disruption in that ability to recognize you as an individual. So what we have is that we have these checkpoint proteins. And so checkpoint modulation, like CTLA-4 agents, like PD-1, PD-L1 blockers, what they do is that what we're trying to do is overcome immune regulation and basically get the foot off the brake, because what these checkpoint proteins do, they slow down the system. They make it so that your immune system cannot just keep going unchecked. So on the left here, again, what we're talking about is this active immune therapy, Sipuleucel-T or Prostvac. But on the right, again, what we're doing is we're targeting CTLA-4, PD-1, PD-L1. So what does that actually mean? So this slide, and again, I'm going to do my best Chuck Drake imitation here, because Chuck basically makes immunology seem really easy. But so what has to happen for cell-mediated response, for T-cell response, you have to have priming of the T-cell. And so what happens is that the cells, the cancer cells, basically have to prime. And again, and as well as the T cells have to be primed. So you get exposure of an antigen to the T cell. Well, that exposure of just the antigen is not quite enough. So you have to have these activation signals as co-priming, which is primarily driven by all these proteins over here. CTLA-4 gets then upregulated on the T cell membrane after it's primed. And so the CTLA-4 expression really happens during the priming phase of the immune response. And then once this gets primed, and again, all of this is really started by this T cell receptor. Once it's primed and basically the T cell is activated, then you get another negative regulatory effect, which is actually driven by PD-1. And then so what happens is that its ligand, PD-L1, which is expressed by the tumor cell, binds to PD-1. And so again, it's sort of the tumor's way of basically having a cloaking mechanism, if you will. So the whole goal of these new blockers, of these checkpoint inhibitors, so ipilimumab basically works during this priming phase. It's blocking CTLA-4, so it's basically, it's allowing, again, the T cells to go unregulated, unchecked, and again, these PD-1, PD-L1 blockers are actually working after the T cell has already been active. So again, this is the rationale, and Dan alluded to this earlier. This is the rationale for these combinations using basically checkpoint inhibitors and active immunotherapy. So by using in combination, you're manipulating on both sides. Well, the other thing you can do is, and thanks Steve Finkelstein for sharing these slides with me, is this concept of radiation-driven immunotherapy. So the fundamental mechanism of tumor control through radiotherapy is basically causes double-stranded breaks in DNA. But then what happens is that because of that, you get this release, again, of all these molecules. And then what the most dramatic effect is that you get release of all these molecules, you get release of this antigen spread, you get what's called the abscopal effect. And the derivation is basically ab is away, scopus is target. So again, what can happen is that after radiation therapy of a primary, you get this antigen spread, you get stimulation of the immune system, and that's why you get occasionally this regression, this shrinkage of metastatic sites. That is what we affectionately call the abscopal effect. A lot of people are taking advantage of this. Stole this from Dan Petrolak. So basically, this is some ipilimumab trials. Again, this is a CTLA-4 modulator. And really what they did in this trial is they took patients who had already received docetaxel chemotherapy, gave single-dose bone-directed radiotherapy, and randomized them to either get ipilimumab or placebo, with the endpoint being overall survival. And what they found in this trial is that basically the primary endpoint really was not met. It was 11.2 months in the ipi arm versus 10 months in the placebo arm. However, when you really drilled down, it seemed to be that if patients did better if really they had no visceral mets. And remember, these patients had already been treated, so this was an advancing patient that had already been treated with docetaxel. So the primary endpoint of the study was not met. Pre-specified and post-hoc analysis suggests that mCRPC patients with favorable prognostic features may more likely benefit from ipilimumab treatment. Visceral mets had an apparent interaction with treatment effects. Several factors appeared to be prognostic for overall survival. So again, looking at this abscopal effect and taking into account this potential of using radiation. And remember, now we have a approved FDA drug that's a alpha emitter radiopharmaceutical that has a survival benefit. And again, it's the ability to deliver radiation intravenously. So now you have a lot of trials that are being looked at potentially using this combination of immunotherapy with radiation. A couple that I thought were interesting, and so is that I think this is a trial looking at using atezolizumab and radium. So this is the safety, and this is a phase 1 trial. And also there's another trial, this is out of Johns Hopkins, looking at radium as well as concomitant use with Sipuleucel-T. So that's why we see some of these, that's the rationale, is understanding the immune system, understanding the effects of radiation, and at the same time, obviously, trying to work with all these drivers, and again, still taking into consideration the androgen receptor. So, in conclusion, Sip-T is currently the only FDA-approved immunotherapy for the patient with metastatic castration-resistant prostate cancer. Checkpoint inhibitors, especially in combination with other therapeutic modalities, represent new opportunities, and I think Dan's going to touch on this. But again, ongoing clinical trials will still be needed, especially utilizing and developing predictive markers. Thanks.